is, I think Vikas has disappeared. The reason why I mention this as a non-institutional perspective is because what I believe is in a non-institutional solo practice like mine, it's very important to understand that referring the patient to the optometrist is not necessarily an option and not necessarily always a good option. Why? Because the kind of expertise which is available with the optometry departments of institutions is not usually available to solo practices. When we're talking in terms of trying to do lenses for patients like ocular surface diseases, with or without dry eyes, or even severe ectasias for that matter. So if you want to be serious about doing ocular surface and any kind of work in this area, my personal belief is that a corneal surgeon or a corneal trained surgeon would necessarily have to have a working understanding of the lenses, if not actually doing the fitting himself or herself. Some of my talk is essentially based only on the academic part of the discussion, but I think seeing the discussion trend that was happening, it's important to understand that there is always going to be the final answer, which is going to be yours in a private practice. Whether the lens fits or does not fit is dependent upon your personal understanding of the thing, and you are responsible ultimately. So it cannot be that, and plus the other aspect which opens up in a private practice is that how often can you replace these lenses and how often can you ask the patient to come back. So these are all factors which become important when you are personally handling the patient and are responsible and answerable to the patient in that sense. So that is the reason which has kept me doing these lenses for so many years. Of course, it also matters that we had a good founding when we did our fellowships, so that credit goes to the institutions where all of us have trained. But it needs to be continued and maintained if you have to offer a complete bouquet of services to a patient who walks into the clinic, whether it is an ocular surface patient or whether it is an ectatic patient or whether it is any other patient. Effectively, you have to be answerable and you have to be able to provide an answer if it is within your limits. Any usage by me is not an endorsement of any specific product. And these are the three brands that I'm using presently in my practice. One is Europa, which comes from Visionary Optics in the United States, Purecon, which you just heard, and Boston Sight, which Srikanth just mentioned in the first talk. And the other aspect of my practice, of course, I think most solo private practices would agree with me, is that my ectasia load is definitely much higher than my ocular surface disease load. I would say it is almost 80-20 in my practice. And why did I put this one up here? Because obviously this has not been represented. The idea of putting it up here is not to teach anybody how to do these lenses, but what I want everyone to understand is that there's a wide universe of scleral lenses that is available today, nationally and internationally, many of which may not be represented here. So the other aspect is there is no one design which is going to fit all the patients. So if you feel that Boston Sight can take care of 100% or Purecon can take care of 100%, it may or not always necessarily be true, because every lens has a design which is proprietary. But obviously when so many exist, it means that each one of these designs has certain limitations, and that's why somebody else thought of making another design. So you have to have a fair understanding. Obviously none of us can have a full understanding of all the varieties that are available, but you need to have a fair understanding that if your particular lens of choice is not doing the job in a given case, there could be an alternative. It's a matter of going out and looking for it. This particular brand moved into Europa as their new lens from Jupiter, and the advantage essentially is that it offers peripheral curves and scleral curves now which have a reverse geometry, and that allows a much easier level of fitting, especially in advanced ectatic diseases and in ocular surface disease patients where the limbus is not in a very good health or a good shape. And the larger optic zone allows for a better quality of vision in distorted corneas. So this is the other one that I'm using. These are the Miniscleral lenses from Purecon. These generally, in my experience, they work for dry eye diseases only. They work only in patients with mild to moderate diseases. I have not been very successful in using them for the advanced diseases or with patients who had a reasonably severe ocular surface disease. Having said that, it doesn't mean that it does not fit. It would be useful in patients with moderate problems. I'm also now using a Boston site from LVPI. Srikanth has done most of the talk on fitting, so I'm not going to touch upon that at all. The only thing which, again, I would repeat is that each lens has an indication, each lens has an advantage. You have to weigh the pros and cons and then take a call as to which particular brand or which particular kind of lens is going to work for a given patient. Just to have a little bit of a different understanding, the aim in all the patients remains the same, but in an ocular surface patient where there is a specific intent, there would be two basic elements. Visual rehabilitation is definitely there, but to my mind that becomes secondary if it is a very severe disease, and surface protection and surface support. And as we heard yesterday, symptom mitigation becomes a very high priority in patients who have very severe ocular surface disorders. And in many cases, scleral lenses would also go ahead to help in healing the surface. So that is something which needs to be understood. And that is why it is now also pros when they say that it's basically a prosthetic device. So a prosthetic device also needs to be understood in the perspective of non-visual rehabilitation aims as to inducing or helping the healing of these patients. Sorry. So there are two elements to any large lens fitting that we are looking at. Visual rehabilitation is definitely important and works as a primary driver in almost 90% of the patients. But there is an extended role for these lenses in patients where healing is an important factor. Stephen Johnson's, that's been the theme of this lecture, of this whole conference. And there it has had a variety of roles to play: symptom mitigation, comfort, and most importantly, surface healing and maintaining surfaces that have been healed. So the key points that I would like to emphasize is, I think that's where the question which Jim also was coming in with, is all of the fitting parameters become much more crucial in ocular surface patients vis-a-vis the ectatic patients that we look at, especially because these are already compromised eyes where the milieu is completely different from what a routine eye would be. And therefore, in my experience, what I have seen is corneal vault is what all of us talk about when we do these lens fittings, but it is the limbal vaulting which is very important in these patients for long-term success, because neovascularization invariably comes in because of two factors. One of them is the material that has been used, which as a standard now has moved into the high decay lenses. But if there is a landing of the limbus or landing of the lens onto the limbal area, then neovascularization of the cornea is of much, much higher probability as compared to a lens which has been well fit. So in these kind of scenarios, using a larger lens gives you a better fit, because vaulting over the limbus becomes a much easier option if you're using a lens which is 18 or 19 millimeters as compared to the smaller ones. Pros probably would definitely be an option, but availability of pros and the cost of pros needs to be considered. And as I keep repeating, it's a balance between the cost, the material, and the fitting patterns that are available to you to give an option to the patient and consider what needs to be done. The problems, again, repeating what has been already discussed in some of the questions, the drier the eye, the lesser the duration of a single wear that these patients can have. Now, there are multiple reasons for this, some of which are physiological, some pathological, and many related to the design limitations of the materials and the science that we have today. Tear exchange being an issue with scleral lenses, the larger the lens, the lesser the clearance that's going to be there. Debris collection either on the lens or inside the fluid is an important problem. As I said during one of the questions, what we have found a solution to is asking the patients to remove the lens, clean it, and then reinsert it. The other thing which has made a difference to my patients is the kind of saline that we use. Normal saline is what is usually monitored and mentioned as the standard default, but using phosphate buffered saline enhances the duration of debris-free period. That's because the pH maintenance or the pH values are far closer to the normal in a phosphate buffered saline as compared to normal saline. So that is something which could be an alternative option that you can look at. It can enhance by at least a couple of hours the collection of debris. Irregular surfaces are a problem. I do not have access to this technology. These two slides are not mine. Effectively, at more advanced markets, it is possible to shape the lenses according to the requirements. So if there is an area which is going to be a bumpy area, they have the ability to make a cut in that area so that it can be fitted appropriately. We don't have access to these lenses yet. I hope sometime in future or maybe in the near future we will get them. The other option, of course, is to surgically manipulate the surface, make it flatter, and then go in and try to do the fitting for these patients. It depends, again, it's a very case-specific solution. If I say can do it, not necessary that every patient can have a surgery done and then can be taken care of. Thank you for your attention, ladies and gentlemen.
Thank you so much, Dr. Vinay. Any questions?
If you are giving this lens to a patient with an epithelial defect, since we do not have any drug exchange between the lens and the, say, outer surface and this, would you advise antibiotic, prophylactic antibiotic drops, or can a drop of antibiotic be instilled in the lens reservoir and given to the patient?
So you have an epithelial defect in a patient with Stevens-Johnson syndrome?
Yeah.
So in those patients, for healing of the epithelial defect, you would be prescribing a PROS lens,
Yeah.
which is a fluid-filled lens.
Yeah.
So what, as you rightly said, the absorption, we really don't know how sure we would be about the absorption of antibiotic.
Yeah.
So if the antibiotic is only to prevent a secondary bacterial infection,
Yeah.
which you would suspect in a patient with Stevens-Johnson syndrome, so once the patient removes the lens to refill it, that is the time, because you don't need an hourly antibiotic for those cases, so it will be just 3 times or 4
Yeah.
times a day. So once the patient is removing the lens, if you want, you can put it, but that also usually is not required, because that's one question which always has been lingering in all our minds. Why is the incidence of infection so low with PROS as compared to the other contact lenses? Like,
No, it's I don't think it's PROS. Let's be very clear. Any fluid-filled
Scleral lens.
lens,
Yeah, sorry,
any
scleral.
fluid-filled
The only
lens
thing
will
that
have
I
infection
feel
risk.
scared about is patient's intelligence to handle the lens in a very clean environment.
so when
the-
it
I
is,
mean,
when,
the hand sanitization and things, they are going to be what even the
so
patient inserts.
when we are using it for a therapeutic thing, it is always that the patient is under care. So the removal, fitting, everything is done in-house. Patient is admitted if we are doing it for an epithelial defect. So if it's a therapeutic use of the PROS that we are prescribing in patient with Stevens-Johnson syndrome, at our institute, usually we get the patient admitted, and that is how we manage the patient.
That may not be the scenario
Exactly.
all over.
Yeah.
See, in
So then
my
it has to-
scenario,
So
it's
you
very
have
simple.
you have to think in
No,
ways.
Meera,
Yeah, so in that,
in my scenario, what we do is we do not add, as you asked, no addition of any medication to the lens. What we do is again the same thing. The only difference is that we ask the patient to remove the lens in between. So I generally do not more than 3 times a day as an antibiotic insertion, because if there is an
more than that is not required.
if it is an
Yeah.
epithelial defect, in principle, I feel that it is not likely to be infected. And the second thing, as far as insertion and removal of these lenses are concerned, we sort of tell the patient or insist that the plunger method be used. It's relatively cleaner compared to the usage of the tripod method. Again, the jury is out on that. We can all argue about it, but that's the way we have been working in that direction. So admission, obviously, as you said, in our scenarios is definitely not an option. Only thing what we do for these patients is we have them under a closer follow-up. So these patients, I generally schedule them as the first patient to come in the morning and the last patient again in the evening before we leave, so that there is a better monitoring. But yes, admission is out of question.
is there any insurance cover? That was one of the questions that was asked in survey for these lenses.
No. In India, there is no insurance company which covers any kinds of contact lenses. I mean, starting right from the soft lenses to RGP lenses. There are some corporate programs where they include the covers, but even those are not covering these kind of lenses, because what happens is the costs are phenomenal as far as their considerations are there. And as far as any layman is concerned, the cost of a soft lens or a cost of a routine RGP is what they understand as the cost of a lens. So why would a lens cost anything more than 2,000 to 5,000 rupees is the first question. But yes, there are certain corporate programs where my patients have been reimbursed, but I think it's more there because it's a personal relationship. You know, the HR takes a call on whether the payment is required. But in a general insurance setup, no, there is no coverage.
I have been able to write letters for patients to get insurance and do not use the word contact lens for a pros lens.
No, that's what I
And then
said.
explain them that it's not a contact lens, it's a treatment and it's a system which is, this is the only thing that will help this
Yeah,
patient.
so, but then we must.
That's a very individual case.
Yes, but one is very unusual, and second is only if you have a definition of prosthetic device to back you up. So pros is probably something which would be feasible if we are, going to really get into the system and try to get hold of it. Most other lenses do not have that kind of literature backup to say that it is a prosthetic device. So maybe yes, maybe not, but I think your point is well taken. Because when we started C3R, we started with the same argument. I have had a whole big, thick file of 200 pages to be made before the first patient was approved for insurance purposes, because it was labeled as an experimental procedure and the claim was refused.
So
the
the
patient
whole,
has to fight for it.
the name PROS means prosthetic replacement, and they specifically did that so that they could obtain insurance coverage
I would
for
appreciate, yes.
the device. That's why
Definitely.
they changed the name, because
Definitely, I'm quite
and
sure.
so they don't call it a contact lens, and they get upset if you call it a contact lens.
Yes.
And they get insurance in some instances in the U.S. as a prosthetic device. That was the whole concept.
No, that's exactly why I'm sure they named it as pros, and that is how Virender must have been able to convince the insurance company. So
Yeah, I think that's a very, very valid point, and as private practitioners, it can, even for institutes, we can send them a thing saying that.
yeah, you can.
It can be done.
But be aware that just sending a letter is not going to work. It has to be a regular, proper follow-up,
No,
which has
if
to
the
be done.
patient asks that can you help, so
Yes.
don't say no,
No.
because with your help, at least there can be a possibility. If you just flatly refuse, then there's no
No,
hope.
but the answer which we give our patients is that you can talk to your insurance company. If there is any query coming in from the insurance company, we are willing to support it with the documents from our side.
No, just give a letter that it's
No,
a,
that's what I'm saying.
it's a
We
device.
would definitely give them the supporting letters which are required. But it's been difficult. I have tried it in the past. It's not
Nahin,
that it
whether
works always.
what I'm saying, whether it works or not, but patient, at least you give the letter, and after that the fight starts.
No, I agree. That's what I said, that is how it has been in our past experiences with other new procedures also. Oh, renaming is not so simple.
As a prosthetic device.
Yes.
Renaming is not
I
so
never-
simple.
In majority
cut
in
down
my
the cost.
literature, you will see it's just a device. I've never called it lens. Miniscleral device. On my label, on my literature, it's mentioned like that, ma'am.
See, that is not going to be so simple anymore, because as India evolves in its medical device regulations, the moment you call anything as a device, the whole different set of regulations will apply, and therefore it requires a huge amount of commercial expenditure to get a device named as a device. Right now, with the contact lenses being called contact lenses and our systems not having been evolved to the level as they are in the United States, you can sell any contact lens in this country without registration. The moment you call it into a device, it's a medical device. Medical devices are controlled by the CDSCO. And the registration process involves clinical trials, data submission and approvals, renewal of licenses every 5 years with additional post-marketing surveillance every year. So it's a different level of compliance. So are you willing to pay another $5,000 per lens that Gagan will add to his cost if it is going to be a device? That's the question we also need to understand, because we are a very price sensitive market.
So there's a catch everywhere.
Of course, there's a catch to everything. There's a cost.
So let's move on. Thank you so much,
Thank
Dr. Vinay. I would request Shrikant to come over.